Welcome to the American Academy of Thermology's Thermology Expert Series. I'm Dr. Robert Kane from Kane Thermal Imaging in Redwood City, California, and I'll be interviewing experts in the field of medical thermology to help healthcare providers and patients get a better understanding about how this technology can help in patient care and ultimately provide more effective treatment. Today, I'll be interviewing Dr. Robert Schwartz of Piedmont Physical Medicine and Rehabilitation in Greenville, South Carolina. Dr. Schwartz has been a noted member of the thermology community for many, many years. He is an author, a speaker, a guest lecturer, staff on medical universities, not to mention many other credentials through his name, certified by many boards. And we're going to be talking with him today about the use of medical thermology in the pain practice and how it can provide an advantage that might not otherwise be available. So Dr. Schwartz, welcome.
Thank you for having me.
Happy to have you. So let's talk a little bit about your practice first. Maybe you can tell us a little bit about the types of patients you see, the conditions, so we can get an idea of what's coming in your office, and then we can go delve a little deeper into medical thermology.
Okay, so my primary specialty is physical medicine and rehabilitation. I'm boarded in that, but I'm also a fellow in vascular medicine. And it's those two combination of specialties are important, in particular in my practice as it relates to medical thermal imaging, because medical thermal imaging actually acts as a bridge between the two fields. So we see an awful lot of patients with complex chronic musculoskeletal pain conditions. It can be anything from somebody with reflex sympathetic dystrophy to mixed headaches, migraines, failed neck pain, back pain, failed surgical necks and backs, joint pain, fibromyalgia, non-gastric abdominal pain, non-uterine pelvic pain, non-cardiac chest pain. We see a whole host of conditions that others really don't know how to deal with, and that's our patient population.
So you're really taking care of a lot of the patients that are falling through the cracks in the general system, meaning traditional methods have been tried, the general protocols have been implemented, but these patients aren't getting better. Is that correct?
Yeah, we either handle those that really don't have another place to go, or where the system doesn't have something better or worthwhile to offer at all. Just as we're talking, the peripheral neuropathy population comes to mind. We see a lot of neuropathy patients. When you think about diabetics, I mean, these are people that have small vessel disease and they lose the nerve fibers in the ends of their feet and then their hands. And that's a vascular disorder, yet it's a neurologic disorder because the neuropathy is what happens when they lose the nerves. So that combination of neuromusculoskeletal and vascular disease is a perfect fit for our office. We actually offer a form of treatment that restores neuropathy in medical thermology, kind of fills in a great gap for small fiber neuropathy, whereas traditionally EMG and nerve conduction only looks at motor and sensory neuropathy.
Let's talk about that a little further. So if somebody was coming in with this exact condition you're talking about, there's some sort of peripheral vascular condition that has a neuropathy component, what would normally be the workup in a physician's office that doesn't have access to thermography? And what do you think would be missed by that workup?
Well, so first thing is we don't do thermal imaging on everybody that walks in the door. We kind of go after the normal low-hanging fruit first, and that could be for fibromyalgia or a failed neck or back. But we do a comprehensive history and physical. We're holistic in our approach. We look at things that others won't look at. We're open to other thoughts and ideas. And the first thing that we do is we just let go of this idea of a unifying diagnosis where just one simple thing is going to fix you, because the patients in my office, that's just not going to be the case. So we call it reducing total load. We try to get all the mud out of the water, clean it up so they have a chance to get well. So the traditional thing is to look at structural studies, X-rays, MRIs, CAT scans, and they're just that, they're structure. They tell you about structure, but they don't tell you anything about function or physiology. Mm-hmm. So we do a lot of functional or physiological assessments in our office. EMGs and nerve conductions, for example, are like voltometers for the motor nerves that make you move and the sensory nerves that make you feel. It kind of feels like you touched a doorknob and got a shock or a little pin. And we're literally just seeing if your motor and sensory nerves aren't working right. maybe you've had chronic neck or back pain and you just think it's a strained ligament or torn muscle, but may very well be it's a certain kind of nerve irritation that is not bad enough to need surgery, but no one else has even bothered to look at or validate it. The sympathetic nervous system is a different portion of the nervous system. Doesn't mean you get sympathy. It's just they could have called it crowbar nerve, but they didn't. It's part of the fight or flight system. It's what makes your pupils dilate. It's what makes your heart beat. It's what makes you breathe, what makes your bowel and bladder tell you need to empty. Your fingers constrict when it's cold and swell when it's hot. These are things we call automatic function. And most people don't look at autonomic nervous system disorders. And medical thermology is tremendous for that. We put all of our patients under cold stress in a cold room, a cold environment. We have them disrobe, and they're there for about an hour. And so it's cold enough that they're not shivering. They're certainly not perspiring, but we're getting an elevation of their heart rate. Their autonomic nervous system is getting challenged. And then we map or we measure where that skin temperature doesn't actually equilibrate. Mm-hmm. So if you take a hot glass of water, you put it in the refrigerator, you don't expect one to have to get hot and one have to get cold. You expect it to equilibrate. We expect you to do the same thing. Right. And if you don't equilibrate properly, medical thermal imaging is a sympathetic skin response study under cold stress is a fantastic way to vasomotor map and document what's going on. So we'll do that on the patients that we can't get our normal response from or our normal findings that would help us take care of a problem like EMG and nerve conduction. Mm-hmm. We also use musculoskeletal ultrasound quite a bit where we can image up torn or stretched ligaments. Mm-hmm. And then we do injections to regrow the ligaments and to regenerate. We give restorative therapies and exercises and cognitive things to do to help restore your body. But the sympathetic system just isn't evaluated any other way. So that's when we pull in medical thermology.
Well, and that was my next question was, are there any other ways to measure the sympathetic nervous system, or is that just overlooked during the traditional diagnostic process?
Well, it's not entirely fair to say there's no other way. There are other ways, but there's nothing that offers the virtues of medical thermology. So just if you're listening to this, you might say, well, gee, I hurt my knee or I had knee surgery or I hurt my back or my neck, my ankle. And, when the weather's cold, it bothers me. But, you wouldn't, I say all the time, well, which doctor would you tell that to? And if you did, which one would you think that would even pay attention to it or know what to do? It's what I call a dysautonomia. You're not supposed to have that weather sensitive pain component, certainly not forever. It's okay to have it 2, 3, 4, 6 weeks maybe, but it should go away. It's just like you sprain your ankle. It shouldn't bother you forever. It should go away. But if it doesn't, that burning pain like you feel in a sprained ankle or that weather sensitive pain that comes on when there's a hot front or extreme hot, extreme cold, or more likely cold in most people, or rain fronts coming in, it just hurts and it's not supposed to. It's not a wives' tale. And so medical thermal imaging can actually visualize this because we put you under a cold stress. We put that portion of your autonomic nervous system under stress. And the thing that medical thermology does that nothing else does is it does what we call vasomotor mapping. And so it tells you the distribution and quality of that change. Mm-hmm. So you might have like a localized hotspot in a single muscle group. Okay, well, that means one thing, but you may also have an entire limb is cold, and something like that we would call dystrophy. Or you might have, well, it's cold, but it's only tracking, for example, what we call a C5-6 distribution. A dermatome, which doesn't always have to follow that, but that's just to give you a picture of where it's tracking. And that tells me, well, anything that tracks in a C6 distribution could be generating that response. There's no other way of measuring dysautonomia or autonomic dysfunction that actually gives you an idea of what's generating the response and helps you to formulate a treatment plan to actually correct or repair the response. Mm-hmm. And that's one of the great things about medical thermology.
You said a couple of things here. There was so much in what you said that I want to pull from, but one is that some of these quote unquote things that we've dismissed as aches and pains of aging, right? Oh, it's my arthritis picking up because it's cold outside. I know it's going to rain tomorrow, that kind of thing. But that's not necessarily aging. That's conditions of the sympathetic nervous system, which you're calling dysautonomia. And that we need to start rethinking some of these smaller symptoms that we've written off to incorporate it into a larger treatment plan to give better care to the patient. And that thermography can actually qualify that and measure that for us in a way that becomes actionable.
Well, so I gotta just make a small commentary. So everything you said is fantastic, but I don't want the audience to hear this and think that these are small pains. You may have a weather-sensitive piece to your pain, and it may not be impacting your quality of life. But what if it did? What if it was so bad that your hand shriveled up and your bones and muscles were wasted and it looked like saran wrap? I mean, that's the same kind of pain. We call it dystrophy. That's very weather-sensitive. You might look at a fibromyalgia patient who looks just fine, but they're the best weatherman you'll ever know. 6 out of 10 of them will tell you they have weather-sensitive pain. You may have thoracic outlet syndrome where your arm goes numb and they say, well, nerves, arteries look great. Well, it's because the autonomic nervous system isn't working right. These things can have major impacts on quality of life. So, but it's like everything else. Severity of illness justifies intensity of service. And if you learn to live with it and it's not that bad, then truthfully, you're probably not in my office anyways. Mm-hmm. But you may have given up. You may say, oh yeah, my bowel's always a little irritable. Yeah, I go to the bathroom a lot. And sometimes my heart feels like it's racing, and they all say there's nothing wrong with me. Well, those are all part of the autonomic nervous system.
Right.
We see people all the time that are hypermobile, just loose joints. They're not like what you call Ehlers-Danlos, so loose that you are double jointed inside of a box in a circus. They're not that kind of person. They look just like you and I, but see, I can't bend my wrist. I'm trying to can't figure it out. Try to get it shown on the video. See, I just can't bend this past 90 degrees. I'm reasonably average, actually.
Right.
Okay, but some people, they can make their thumb come all the way over here to touch their forearm. Well, that's hypermobile.
Right.
They make their elbows go backwards. You can see mine's got a 20-degree carrying angle. I can't do that. I'm tight. But boom, other people, their elbows go upside down and their knees go upside down. Oh, that's so fun. You're so great. You have so much motion. You're a ballerina. No, they're not happy at all. Those people are not happy.
Right.
Their joints are constantly rubbing each other. They're getting the arthritis. Their muscles are constantly tight, trying to do the jobs of the ligaments. A lot of them have a weather sensitive piece to their pain. Yeah. And the reason is because the ligaments, unlike muscles and nerves, ligaments attach bone to bone. Ligaments are richly innervated by the sympathetic system. That's why when you sprain your ankle, it burns.
Right.
What is that?
A reason not to dismiss some of these quote unquote minor aspects of the syndrome, because they may not be minor at all.
It may not be minor at all. In fact, it might be affecting your whole body. By that time, you are in my office.
And then thermography would be the way to measure this, look at what the effect actually is, and then incorporate that into the broader clinical picture in order to construct the treatment. Yeah,
especially, it's really simple. I mean, there's more to it than this, obviously, but yeah. A simple take home is just ask yourself or your patients, do you have weather sensitive pain? Mm-hmm. If they say yes, maybe you should listen to it instead of just dismissing it. And if your answer is yes, you should be saying why. Why does this weather affect you so much? It's not supposed to. Mm-hmm. So if that component is present, there's another very clear indicator, and that's just light touch. I can't stand the sheets on my bed, or I don't like it if my husband touches me, or if I brush up against something, my clothes hurt me. Oh, a lot of people, you must be a little wacko. Well, probably not. You may very well be overly sensitive. We call it allodynia, mm-hmm. pain to non-painful stimulus. And these are clear signs that you have a dysautonomia in the sympathetic skin response. Sympathetic medical thermology is a fantastic study to actually prove that you have it and what's generating it. You may have gone to a chiropractor, the guy popped me and it hurt me for a year. Well, or gee, he says he just touched me and I was on the ceiling. That's not supposed to happen either. Okay, so that's telling you that the sympathetic system's involved.
Right.
So, you should be sharing that. You shouldn't just be saying, oh, I'm a nervous person, I'm anxious. Now, you might be. You're allowed to be that and have sympathetic dysfunction. By the way, remember, the fight or flight system mm-hmm. is a part of the autonomic nervous system. So maybe your anxiety is just another sign that you actually do have this.
So now, what percentage, and I'm just going to ask you to guesstimate here, what percentage of the patients that come in with chronic pain that's severe, because this is really your practice now, have this autonomic nervous system component to it?
6 out of 10.
6 out of 10. So that's pretty significant.
Yeah.
That's pretty significant. That means 60% of people are not going to respond as effectively or at all if this piece isn't diagnosed and managed appropriately, correct?
Yeah, absolutely. So that's a very important point too. So let's say you have like a lumbar radiculopathy, whatever, and we treat that. And that's not that hard to treat, actually, relatively speaking. And then we find, oh, you've got strained ligaments and interspinous ligaments in your back or in your hip, and we do an injection or medication or treatment to regrow that. Well, it's supposed to work. In fact, it does work. It works great. But you might say, that shot really hurt. Or, it hurt me for 5 days afterwards.
Mm-hmm.
So I'm starting to listen. It did. So then what happened? Well, it got better, much better. Oh, we got out of the woods. You're going to be fine. Oh, it took weeks for it to get better. Well, did you get any improvement? No, I just back to baseline. That's not normal.
Mm-hmm.
Okay. That's telling you that the treatment for the injured tissue is never going to work. It's telling you that what's going on is that the sympathetic system is monitoring that injury site. And when you start mucking around with it, it just starts dieseling like a car engine that won't shut off.
Mm-hmm.
Watching myself, this reminds me of a patient I saw once. I was in the hospital on rounds and went to do the EMG test just to check for carpal tunnel. And her hand is like this, and I'm supposed to do this test on her. I mean, it's like this. By the way, it's all sweaty and it's all wet. I'm so you're trying to give electrical shocks and it's sliding all over the place. This is not going to go well, number one. And number two, it's not what you got. That's a clear case of dystrophy.
Right.
So there's a spectrum of this. You might just say, I sweat a lot.
Mm-hmm.
Or, my hands don't like it when the weather changes, or maybe it's my leg, or migraines, different kinds of headaches. I get vasomotor headaches. The weather really kicks off a headache. You can really monitor that and find out where it's coming from. And then you have to go and treat the sympathetic system. So you might give medications to increase blood flow. This is where the vascular piece comes in.
Mm-hmm.
Since most people think of dystrophy as a lack of blood flow, which is 95% of the time true. Sympathetic pain can be too much blood flow, 5% of the time or so. But we're trying to increase blood flow. It's like you have a heart attack. I'm not going to give you pain medicine. I'm going to give you some blood flow medicine, try to get some blood and oxygen in your heart. Giving you something with depressed respiration on narcotics is only going to make you worse. I actually need to help heal you. Okay. Right. So your entire protocol, your entire paradigm, your vision of care changes completely when you understand that this is what needs to be addressed. Quiet the dieseling down, you get blood flow in the area, take care of the vascular issues, things start to work. The regenerative parts start to work, everything else starts to heal itself.
Yeah. And then the thermography becomes the best way to monitor the effects of this because it's how you found it in the first place. So
this whole thing, is there such a thing as serial studies or tracking studies or studies to monitor progress? You could use studies to validate the disorder, to validate the response to the disorder, or to validate that you even properly did a treatment that would have affected the disorder. Some people get what's called ganglion blocks, injections in the neck or in the head or even in the back for that matter, that are supposed to quiet down or block the sympathetic system. But the person doing the procedure never validated that he actually was successful.
Right.
You would need to do that with medical thermology. You wouldn't know. There's most body parts that you do this in, you would have no clue of knowing whether or not you were successful or not. You would just assume you were, and then you're going by what the patient says. But the patient may say you made me worse, so you dismiss it. But if you were monitoring on medical thermology, you may find out that you did make them worse. They may have had a paradoxical response.
Yeah.
You just don't know. You're guessing otherwise. So there's definitely that, and then there's what we call spread.
Mm-hmm.
So spread as well, I have this thing, we call it Bray-Liu. It's a Frenchman and a Chinese man that described it. You get headaches, maybe it could be even after a whiplash or some kind of car accident or a flexion extension, something. But it's not just normal neck pain. They get ringing in their ears and they get blurred vision and they get nausea and they get trouble swallowing. And okay, this is no longer just neck pain. It's no longer just a normal headache.
Mm-hmm.
And it's a sympathetic dysfunction called Bray-Liu, where you may be able to document where it's coming from. Okay, maybe there's a ganglion here you got to work on, or here, or even in the back of your mouth, or something to quiet this thing down. Then they start responding. They might come back, a year later and say, my hand is always cold. I hit my elbow. I was playing tennis, and the surgeon wanted to operate on it, and I was like, thought I'd come back to you before I let them cut me. Well, do you have any unusual problems with your elbow? Well, no, but my hands turn blue when it's cold out. All right, they're telling you that autonomic nervous system is involved, mm-hmm. and that the surgery may not go well. This is an example of a case where you got to be careful. So there can be spread. I had a patient came to me from Florida, the University of Miami once, who had dystrophy of her leg, and no question about it. And we went back to them because her shoulder was hurting, and they said, "Oh, it's spread. You've got dystrophy in your shoulder." And they did sympathetic blocks and treated her, and it didn't work. So she didn't know what to do. So she came to see me, and we ran the sympathetic skin response medical thermology on her. It was normal.
Mm-hmm.
I said, "Well, you don't have dystrophy of her arm." She goes, "Oh, no, it's spread." I said, "No, we checked you out on ultrasound. You have a rotator cuff syndrome. We treated her shoulder and she could move it again."
Mm-hmm.
But they just assumed it had spread because they never validated it to begin with and didn't monitor it to see if it did. It's just because dystrophy and sympathetic pain can spread. Right. So that would be an example of how you can both use serial studies to monitor progress of disease or spread of disease or resolution of disease.
Mm-hmm. No, excellent. And this is exactly what we're talking about. We're trying to take these patients that are kind of hitting the wall and they're not really getting any better and something's being missed, and finding that those pieces of information that are key in order to getting them back on track and getting them well. In your case, in the case you just described, this was just someone that was misdiagnosed. They thought it was a sympathetic nervous system problem and it was a rotator cuff tear.
Yeah. I'll tell you another thing that's really valuable for this. Sometimes just validating a complaint is very important. Mm-hmm. Both to the physician and the patient. Because it's a visual test, so you can see the results. You can share that with your patient. And so you can say, well, look at it. You've got this sympathetic response and it's tracking from here to here. And they go, oh, that's exactly what I heard. Mm-hmm. Well, you know what? I believe you. Not only do I believe you, I now have 4 or 5 things I can do that are going to try to attack that system, and we can try to restore it back to normal. Mm-hmm. Oh, I just thought I was anxious, and so much my stomach's bad, I get so nervous. And, oh, well, this is all the same paradigm of care. Oh, I get so bad, I go to the ER. I know my heart starts palpitating. Oh, hey, you got to understand this is all the same conditions. It actually is one condition, and that when you do that and you let yourself ramp up, all you're really doing is adding kerosene to the fire. Mm-hmm. Because the system's on overdrive to begin with. It's actually the part of the nervous system that makes you go into fight or flight. So what I'm trying to say is that this gives you a different way to both validate the disease and then have a discussion with the disorder where the patient can start to understand how to become part of their own paradigm of care. Right. They can start to contribute to their care. Oh, I was really bad. He told me to look at the weather. It's so nice outside. And my husband came in and he goes, oh, there's a tornado coming. It's like a day away. Oh, wait, every time it's a day away, I start to hurt, even though it looks nice outside. It's the fronts coming in. I finally figured that out. I figured out if I wait a day, it goes away. I get better. I don't have to go to the ER.
Right. I think that's a great point too, is that more and more, you probably see this in your practice. I know I see it with patients I work with. Patients want to be more involved with their care. They want to understand it. They want to be able to do their part. They're tired of just following instructions that they don't understand and then hoping it's going to go away. And what I'm hearing you say is that medical thermology helps with that empowerment by being able to see it and understand it better. They now feel a part of their care and they're empowered, which is critical in order to get patient compliance and to truly have all the information you need to get them well.
Yeah, I think it's very important. I like to call it rowing in the same direction. It's not just a shared decision-making model. It's like we're both trying to get you going to the same place called wellness. And now you, not that you haven't been trying, but what you've been trying, you didn't know how to get there. Yeah. Now you're starting to, it's scary. It's tough when you have no idea what to do, but when it starts to make sense, I can do these things. I can get an Epsom salt bath. I heard magnesium causes increased blood flow. I can get in a hot bath. I take magnesium pills. There's things I can do to actually increase my own blood flow.
They are part of the process, and that's critical.
Yeah,
it's critical. So we are running up towards the end of our time together. The last questions I want to ask you is, if somebody wanted to get involved in the field of medical thermology, you're a physician, you're working with pain, what would be your next steps? How can they learn more about what it is, how it works? How can they start to learn how to incorporate this into their practice?
Well, so the American Academy of Thermology, in my opinion, is the premier organization in North America for the scientific education and training of medical thermology. And even if you're a patient or you're a technician or a physician, it's a great resource. There's a lot of free things on there. We have guidelines for care telling you how to do neuromusculoskeletal, breast applications, veterinarian applications, oral systemic applications. People are familiar with COVID and fever detection, and actually is a way to do that properly. And the American Academy of Thermology has free courses on how to do thermal imaging properly.
Mhm.
So if you're a medical professional or a technician that's trying to get trained, we encourage you to join the organization. We have something called the Courses Online section of our website. It's a separate domain. We have many, many online self-tutorial courses, 8 hours, 12 hours, 16 hours, 24 hours. You don't have to take them all at once, but you take them at your own time period, and then we can proctor them afterwards. But it covers the nuts and bolts from what is a infrared detector. Well, we don't want anyone to think of this as a camera, like the little point and shoot that you're getting done at the drugstore. The grocery store is probably a waste of time. But a true infrared detector with a microbolometer, if it was called that, people wouldn't just think of it as just a camera. It's not. It's a process that measures infrared radiation. That is a form of heat and puts it into an image that we can see it. So it goes from the nuts and bolts of how to set up a lab, how to create a lab, what are the different camera types, what are the different software types, what are the different palettes that we use, and then what does it mean? How do you do the test, and what does it actually mean if you're looking at it as a physician, and how do you interpret it? If you want to go that far, we can teach how to interpret and write reports.
Right, excellent. And then let's say somebody went that direction. They got the basic information, they took the trainings online, they're becoming versed in interpretation. What is the best way to stay connected with other practitioners that are doing similar work, and to really share from the collective wisdom of people that have been out there, such as you, 40, 50 years, that have a tremendous amount of information to give above and beyond the basic training?
Well, I would recommend the AAT, American Academy of Thermology. It's aathermology.org. And, we have annual scientific sessions. We have, even if you took a physician's interpretation course, we often do like half-day seminars where we just run through cases and questions and answers. And we do that for anybody that's trying to become member certified. We give them 90 days of access where I'll proctor them. And somebody wants somebody on board, somebody who's qualified will proctor them and help them through the education training process. There's lots of resources coming out. For example, again, I'm board in physical medicine and rehab, but Elsevier is a well-known medical publishing company. Elsevier Press has a series called Secrets. It's for every specialty. It's like what the residents use to train for board exams, things like that. And the new edition of Piedmont Secrets is coming out in January 22. And I've written the chapters on dysautonomia is more common than you think, and also on peripheral vascular medicine. There's editors of some national journals are becoming members of the AAT now, and publishing on using medical thermology and vascular medicine, venous disorders, things of this nature. There's lots of activity going on. You just like any other professional organization where you're trying to find the resource, you go to the place that everybody comes to it. So that would be AAT.
Yeah. So in other words, I mean, you could go online and do Medline searches. You can try to start looking for this in textbooks. But if you really want to just get plugged in and not have to do all that extra detective work, you can come to the AAT, you can join, you can come to the annual conferences, you can get trained, and then you'll be plugged into the community that's doing it and be referred to the resources that are out there, whether it's a scientific paper or a textbook chapter, so that you can be up to date on the latest materials.
Yeah, if you become a member, we have something called the members only section. And there's a huge database in the literature, in the Knowledge Center, a huge database of articles. And we also have something called the Atlas of Thermology, and then the Atlas of Abnormals. So the Atlas of Normals, we kind of give small little sound bites, if you will, to anybody to get them interested on this is what a normal study might look like for the various different kinds of studies. But the Atlas of the Abnormals, you need to join if you want to see a full case report. We might give you like one sentence, but it'll correlate the medical thermology study with an MRI, with the CT and EMG, with office notes, with pathology reports. So that's the point of the Atlas of Abnormals is to correlate the medical thermal imaging results with a more conventional study that you may be more familiar with.
Right. Excellent. Well, I think we've come up to our time. I want to thank you, Dr. Schwartz, for taking the time out and doing this interview. I want to thank everybody that's watching this for taking the time and watching it. If you do have more interest in medical thermology, please contact the AAT. We'll have a slide up with contact information after the interview closes. We'll have some show notes in the comments section on YouTube just to summarize some of the material, and hope to see you again on future interviews. Thanks very much.